Welcome to Medical Logistics 101 Abdominal Pain Overview. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Location differential. I like to think of the abdomen as in zones. Right upper abdomen, gallbladder, liver, biliary tree issues, right lower abdomen, appendix, ovarian issues, or urolithiasis, such as kidney stones. Left upper abdomen, spleen, stomach issues. Left lower abdomen, diverticulitis, urolithiasis, again, kidney stones. Diffuse, not localized pain to any specific area, sometimes seen with small bowel obstruction or ischemic bowel, where the blood flow to the bowel itself is not getting where it needs to go. Epigastric pain, that would be upper abdomen, seen with pancreatitis. And pelvic pain, think ovarian torsion, a situation where the ovary is twisted in such a way that its blood flow is compromised, a very time-dependent diagnosis. Also, pelvic inflammatory disease, or PID, and of course cystitis, which would be just infection in the bladder itself. I guess you could potentially include in men prostatitis. Exam findings: palpation. I'm just palpating on their abdomen. Do I see guarding? That is, when I press in on their abdomen, are they exquisitely tender? Do they have rebound tenderness? When I release after pressing on the abdomen, are they exquisitely tender? These are what we call peritoneal signs. These are later findings. They may not be present early in the disease process. Appearance: do I see scars from prior surgeries on the abdomen? Distension, hernias. If there is a hernia, does it easily reduce? Auscultation: do they have high-pitched tinkling sounds of their bowel, or do they have no bowel sounds, silence? Consider pelvic exam, rectal exams, and if you do a rectal exam, certainly look for occult blood. Labs and imaging. Labs would include that I normally get a complete blood count, complete metabolic panel, a lipase. That's mainly looking for pancreatitis, urinalysis, and a lactic acid. Again, as I've discussed in other videos, lactic acid is a good marker for infection. If you saw elevated lactic acid in someone with abdominal pain, you really need to be concerned. Upper abdominal pain, I always get an EKG and cardiac enzymes on these patients. Sometimes patients can have chest pain, but they're really describing it more as upper abdominal pain or epigastric pain. So the EKG could potentially catch someone having a heart attack, also known as an ST elevation MI, STEMI. Imaging: bedside ultrasound is quick for the focus abdominal sonographic test, or FAST. It is very helpful for just getting a quick look at the abdomen, particularly for a very deadly disease process called an abdominal aortic aneurysm, a dissecting aneurysm. FAST will catch that immediately, and it's one of those disease diagnoses that you've got to catch pretty much on patient arrival for them to have a chance at survival. CT scan, that's the workhorse, the test of choice in most instances, but it's not for gallbladder disease as the first test. That we a lot of times will diagnose gallbladder disease on a CT scan. The test of choice for gallbladder disease would be an ultrasound. It also, and this is an important point, cannot rule out ovarian torsion, the situation where the ovary is twisted in such a way that it is compromised its blood flow. Only ultrasound can diagnose ovarian torsion, not CT. Only stable patients go to radiology. This is an important point and reminds me of a story from a long time ago. Many years ago, before ultrasound became so widespread in the ER, there was a radiology attending who liked to show every year this picture on the screen of someone having an abdominal CT scan, abdominal pelvis CT scan, and it showed very perfectly, the test had been done with IV contrast, it showed a dissecting abdominal aortic aneurysm. And he said, I always tell my patients I do not like seeing this picture. And the point was not that the CT couldn't diagnose a dissecting abdominal aortic aneurysm, but by definition, that patient was not stable enough to be in radiology. They needed to be in the ER. Ideally, they needed to be in the operating room. Red flags that we look for: persistent tachycardia, hypertension or low blood pressure, fever with very localized pain. That's an ominous finding. Guarding or rebound on exam, as we discussed, were peritoneal signs that we look for. If you have a history of syncope in someone with abdominal pain, I've seen that before with abdominal aortic aneurysm dissection. Ectopics, always get an HCG, a pregnancy test. Tubals don't count, as I like to tell nurses. I've had patients before that have had a tubal and they're still childbearing age, they still have a uterus. They're going to get a pregnancy test, because I've had patients before with a history of a tubal ligation And if they get pregnant, it's almost guaranteed to be an ectopic pregnancy or tubal pregnancy. Elderly with vague symptoms. That's always a risk category you watch for. Big bucket list. Inflammatory causes. This would include appendicitis, which is going to be right lower quadrant pain, certainly in the later stages. Cholecystitis, or right upper quadrant pain. Diverticulitis, right left lower quadrant pain. Pancreatitis, that's more epigastric or upper abdominal pain. Gastritis certainly can be more generalized symptoms. They're probably going to give you a history of vomiting and diarrhea. For me, that is a diagnosis of exclusion after I've excluded more serious causes of their abdominal pain. Obstructive causes, small bowel obstruction or large bowel obstruction. With these people, I've often seen that their pain tends to come in waves. Certainly recommend a rectal exam with those patients. I generally do a rectal exam with all abdominal pain patients. It makes sense that the pain comes in waves because the normal peristaltic action of our gut that slowly moves bowel contents along. It's kind of a smooth muscle squeezing type movement, so it makes sense that it comes in waves. Hernias, again, is it reducible? Is it incarcerated versus strangulated? An incarcerated hernia is a hernia that basically, when I try to reduce it on exam, it doesn't go back in. Strangulated hernias are an incarcerated hernia that has become twisted in such a way that blood flow has been compromised. Beware of umbilical abscess. I've had patients before that had an umbilical hernia that did become strangulated. It was incarcerated. You couldn't reduce it, push it back in, and it had become strangulated where blood flow was compromised. What I would say it looked like to me at the time, looked like if you took a cherry tomato, you sliced it in half and stuck it on their belly button. You can imagine that kind of looks a little bit like an umbilical abscess, but you certainly wouldn't want to make an incision like you would with a normal abscess. Kidney stones, ureterolithiasis, pyelonephritis. These are late findings. Sometimes, and this is kind of one of those things where it can unfortunately happen. Someone that has a history of a kidney stone, it's lodged in the ureter, you've treated the patient, they've had the CT scan, we know what your problem is, we know what's causing the pain, they've had fluids, they've had pain medication, and at that point they don't have infection. But I always tell patients in that situation, I said, look, we're going to have you follow up with a urologist for close follow-up, but you have a foreign body, in this case a stone, sitting in your ureter. You're in a higher risk category for infection. So if you develop new symptoms in addition to the pain, such as fever, chills, you need to get back to the emergency room immediately. That can progress fast with pyelonephritis. Big bucket list continued. Vascular causes. Abdominal aortic aneurysm, very deadly, has to be recognized immediately. And again, that focused abdominal sonographic test, the ultrasound right there at the bedside, can catch that immediately on arrival. Mesenteric ischemia, where you have a compromised blood flow to the bowel. CT scan with IV contrast, we usually catch this. If it's upper abdominal pain, always get an EKG and cardiac enzymes. Hollow organ issues, this is a little less common. Someone could have a perforated ulcer. They could have bowel perforations from a diverticulitis that has ruptured, or malignancy. I've had a patient before with a carcinoma, a cancer at their cecum of their bowel, and it had literally grown through the wall and perforated that, releasing bowel contents to their abdomen and producing peritonitis. She was very sick. But the issue with that is that it will produce what's called free air. That is air that's not in the bowel, but loose in the abdomen, where it's not supposed to be, along with bowel contents. In the old days, before we had CT, those patients would usually get an upright x-ray of their abdomen, and you would see free air under their diaphragm that extended from the edge, all the way from the edge of the diaphragm all the way over, not the gastric bubble. But that was a way in the past that we diagnosed free air on an x-ray. These days, mostly rely upon CT. Big buckets continued. Pelvis, women issues, PID, pelvic inflammatory disease, ovarian cyst, ovarian torsion. CT can diagnose ovarian cyst, but not ovarian torsion. That's an important point to realize. If you could have someone, if you think about it, who had pelvic pain and the CT scan that you did showed that they had an ovarian cyst, they can also have an ovarian torsion, which would not be apparent on the CT scan and require an ultrasound. So you would not want to make the mistake of diagnosing an ovarian cyst as their cause of pain when in reality they have an ovarian torsion, where that ovary is not getting blood supply. Only can be diagnosed on an ultrasound, and it is very time-dependent diagnosis. PID just stands for pelvic inflammatory disease. Ectopic pregnancy, dysmenorrhea. Ectopic pregnancy, we're going to catch that if we're certainly doing a pregnancy test, and they'll need further workup, including an ultrasound to actually visualize it. depending how far along the pregnancy is. But dysmenorrhea, abnormal menses, for me, that's a diagnosis of exclusion for women after I've excluded more serious causes. And men certainly can have prostatitis. Rectal exam will be very helpful in diagnosis and can be done immediately when they arrive. Testicular causes. Again, testicular torsion, much like ovarian torsion, is very time dependent. You need an ultrasound. I have seen patients before that had urolithiasis or kidney stone in their ureter. It can sometimes radiate to their testicular area. Epididymitis, common cause of testicular pain, really far more common than testicular torsion. Disposition, who can go home versus admits and transfers. You always reevaluate after interventions or treatments. Abdominal pain workup is often a snapshot, and everything may look different in time, including exam, labs, and even imaging. This situation can change rapidly, and their symptoms can change rapidly. And I always have the discussion with patients that it's just literally a snapshot in time, whether I'm talking about the exam, labs, or even imaging. Closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss.